Hello and welcome to this podcast from the BBC World Service. Please let us know what you think and tell other people about us on social media. Podcasts from the BBC World Service are supported by advertising.
Hello, I'm Claudia Hammond and this is Health Check from the BBC. And Professor Matthew Fox from Boston University is joining me today. How are you?
Doing well, thank you.
Well, we have a surprising amount to discuss about COVID-19 today. And I must say, Matt, I keep thinking we'll run out of new things to say about it. But, I mean, it's really not the case, is it?
Unfortunately, it's not. I mean, with a new infection that's caused a global pandemic, I think we can expect that there will be things that we continue to learn for quite a while.
Later on, we're going to hear from a doctor who told me about the really extraordinary experiences that he has every day of treating patients who are seriously ill with COVID, yet don't believe it exists.
We've had patients who yell at nurses, and I think that takes a psychological toll on the ICU in general. I know way more nurses and physicians and other staff who are seeking out counseling now on the tail end of Delta that never would have considered it before.
And we've got the results of a new trial which any pregnant women who've been worried about getting vaccinated might find reassuring. And before all that, could you be one of those very rare people who are resistant to the coronavirus? And they really are rare. Now, we know that some people have a genetic susceptibility to certain diseases and that they'll become more ill than others if they get them. But the opposite can exist too. And a group of scientists from 10 countries is hoping to find the very rare individuals who are genetically resistant to the coronavirus. Now, this doesn't just mean they don't get symptoms, because lots of people catch it asymptomatically and can pass it on to others, but there might well be individuals who've been exposed to the virus, have repeatedly tested negative and haven't mounted an immune response to it. And these are the people the scientists want to find, because if they do, they might hold the key to developing specific drugs to protect the rest of us from COVID. Evangelos Andreakos is part of the team, and he's an immunologist at the Biomedical Research Institution at the Academy of Athens in Greece. And he told me that since they announced their quest in the journal Nature a couple of weeks ago, they have been inundated with people getting in touch, hoping that they are the ones who are resistant.
Yes, we had an unprecedented reaction, a reaction we didn't expect. So we started getting thousands of emails, but also other members, for example, people from Ireland contacting the leading researcher from Ireland, people from Italy contacting the leading researcher from Italy. And most people come from the idea that they are resistant to the virus because they think they have been exposed to people that had the infection and they didn't catch it. And I have to warn people here that the fact that they didn't get the infection, even if they meet the criteria of the study, doesn't mean they're not going to get it in a second opportunity of exposure. And indeed, we know that people that we had identified as volunteers for our study from the first wave actually got the infection in the second wave or third wave, and some of them got hospitalized. So what I would like to stress, because before we go to the actual details of the study, is that vaccination is still the primary, the best way for them to get protected.
Yes, so it's still very important for people to get vaccinated if they have vaccines available to them where they live in the world.
Yes. And also I have to say that in our study, people that fit very well to being volunteers for our study are not excluded because they get vaccination, but it counts the exposure they had in the first and second waves.
And what is the profile of the people that you are looking for?
We're looking mainly for, ideally, a family, sleeping partners, a husband and a wife, where one of the sleeping partners gets infected. Children get infected as well. This could be the most ideal scenario. But one person within a family doesn't get the infection. And this is a person that lived and didn't get any special protection, wearing masks and so on, living next to the person that got infected for up to 5 days. So this is the primary criterion. And then we look for additional information that these people were exposed again. For example, in their work environment, public transport, in a different occasion with friends, so that if we identify people with repeated exposures that didn't get infected, that would be great. And maybe I have to stress here that we're looking for people that have the actual negative test at these times. Not that they think, but they really have negative PCR tests. Everyone knows these days what PCR tests are. And we're also then testing these people. They didn't develop antibodies against the virus because someone can be negative despite this big exposure.
So it's not the asymptomatic people you're looking for, is it? This is people who actually tested negative, because there are lots of people who are asymptomatic, they don't get ill themselves, but they pass it on to other people. That's not what you're looking for, is it?
Exactly. The symptomatic still get infected, still carry the virus, they can infect, and the causes and the biology for people being asymptomatic is different. So we're not looking for people asymptomatic. We're looking at a different category of people that are resistant, so they don't get infected by the virus. So although the virus is in touch with the airway and the lung, the virus actually doesn't manage to enter the cells, it doesn't manage to replicate within the cells.
And do you think this kind of genetic resistance to the virus is going to be really quite rare? Because, I mean, it's not at all uncommon for one partner in a couple to become infected and the other one not to, but you're looking for something rarer than that, aren't you?
Yes, exactly. So, first of all, it's a hypothesis that these individuals exist. We think that they will be very rare. And why we think that? Because that's what we were taught from other infectious diseases, from what we know from the past. And I'm going to give you an example. When I was a student, I still remember that publication that I read about HIV, an individual, this genetic variation being present in the family, and this person would not get HIV no matter what. It's still a rare situation, but it can be found in some populations, it's present. That's not the only precedent. There are precedents with malaria. Sickle cell anemia is another prominent example. So there is background, there is history of resistance to other infectious diseases.
And once you've identified these people, who may be very rare people, what are you going to look for genetically?
We are going to look genetically at areas that are different in these individuals compared to individuals that get the infection and get the virus. And even if we identify a single genetic area or a single gene or an area next to the gene that confers resistance, that will be major because that gives us the possibility to target for therapy, for prophylaxis, for treatment.
Are you confident that you will find somebody who does have a genetic resistance to the virus, or even several people?
Yes, we are confident. It's a very difficult task, a gigantic task, I would say, but we are confident we will identify some, or at least one. Even if identifying one, it will be major. We are very confident because we have a very big consortium and lots of information on the opposite side, people that get infection. So we're confident for that. And today's technologies and the way we can screen and the way we can analyze DNA and the tools available, that will assist tremendously our studies.
Evangelos Andreakos, and Professor Matt Fox is still with me. Now, Matt, of course, anyone who's not sure they've had COVID yet is bound to hope that they're the ones with the resistance to the coronavirus. I mean, I want it to be me, but it is likely to be very rare, isn't it?
It absolutely is. I think that, a lot of people might feel like they have some resistance to the virus, but there are presumably a very limited number of people who have a genetic predisposition such that they wouldn't actually be able to get infected at all. And it's those people that are the ones that these scientists are really trying to find.
So that means vaccination is still the answer if you can get one. You can't just hope that you're this person.
Absolutely. We can expect, as we have seen with other diseases, the people who are completely resistant are very rare, and therefore the rest of us, while we may have some genetic predisposition to mount a better immune response, we really never know, and therefore vaccination continues to be the best tool that we have to prevent the global suffering that this disease is causing.
Now, HIV was mentioned there, and there are famous cases, aren't there, of people who are resistant to HIV?
There have been cases in HIV where pockets of the population, very small pockets, have been identified to have a genetic predisposition to not being able to be infected with HIV. They are incredibly rare, but the idea is that if you can identify those people, you can hopefully gain a better understanding of how the disease actually works, how the disease starts to infect the cells that it does, and therefore creates the larger infection in the body. And you can use that to target drugs that can be effective at treating these particular conditions.
And that is something that has been attempted, isn't it? And with bone marrow transplants as well from the people who are resistant to HIV.
That's right. I wouldn't say it's been overly successful in developing very specific medications for HIV, but the overall understanding that comes from the identification of those people who are not able to be infected and points to areas that can be targeted for specific medications.
So it is worth having a look to try to find these people.
Absolutely. They can potentially offer insights that we currently don't have. We do have a reasonable understanding of how the SARS CoV-2 infection occurs, but understanding at a level at which we could develop effective therapies is obviously going to be critical as we learn to live with the virus as it becomes more endemic rather than epidemic.
Now, if anyone does want to volunteer for the study, and remember, you need to have lived in a household where others were infected and to have tested negative yourself, ideally more than once, then you'll find a link on the Health Check website at bbcworldservice.com. Now, we heard last week on Health Check about the impact that misinformation about COVID is having on people's decision to get vaccinated. But it's also having an impact on the very doctors trying to save the lives of those who do become seriously ill with the disease. On The Evidence the other day on the BBC World Service, you may have heard me talking to Dr. Brett Campbell, and he works in a dedicated COVID intensive care unit in Nashville, Tennessee in the US. And he told me about his experiences with patients who deny the existence of COVID-19 even when they've been hospitalised with it. Now, he had so much to say that we thought we'd hear some more of his story and the impact that this is all having on staff.
Not everybody that has come in during Delta has been antagonistic. I don't want to give that impression, but certainly a lot more people have been antagonistic towards the care that they're receiving, towards the staff. Many of the people that are coming in during Delta are unvaccinated, and so the unvaccinated population, probably in the country, but certainly in our area, seems to have a very different mindset about what the disease is and what the risks are. And they seem to live in an environment where, or an echo chamber where COVID is overblown, and if anybody actually gets sick, which those are the people that we see, they seem to chalk that up to something besides what we know is the real problem, which is the virus. And so we've had people that come in and accuse the medical staff, who they've never met before that, of being responsible for them getting sick, or just doctors and nurses in general. Like, you guys did this to me.
What do people tell you they think that the virus is, and where are they getting that information from if it's wrong?
Honestly, the misinformation that we're seeing now is less about where the virus came from and what they think it was designed to do, and more about how to treat the virus. So during the Delta wave, we've seen this rash of patients demanding treatments that aren't real treatments for COVID, that aren't scientific, that aren't validated therapies for it, but patients have been demanding them. And some patients who have reached out to physicians that are in other states across the country who are selling something that is, in my opinion, snake oil, and saying, you need to give this because this physician says that this would work, this would save the patient. If you don't do it, then you're denying my family member therapy. The treatment has become a huge aspect of misinformation for Delta. And I think the point is that there's always somebody who's willing to sell something. Now there's a bunch of people buying it because they didn't get vaccinated, they're sick with COVID, and somebody's telling them this is what you do to get better, and they want to believe it.
And so then you have to resist and say, no, this isn't the treatment that's going to help you.
Yeah, that has been very challenging too, because oftentimes we've had people that are transferred to our facility, and when they get there, either the patients or the family members think that the reason they were transferred to our facility, which the reason they were transferred was probably for higher level of care and that type of thing, but the patients think that it was because they could get some other drug, and then they're very frustrated when they find out that we're not doing those therapies. So it creates a whole new source of tension between the patients, the families, and the hospital.
Yeah, that sounds exhausting. And then even just time consuming, negotiating all of that takes time.
Yeah, absolutely. And I think that's one of the hardest parts of covering the COVID unit. It's not necessarily the medical care. I mean, it's long hours. It's a lot of work. You're doing a lot of procedures on these people. They're in a situation where bad things can and do happen immediately, and you have to keep this incredibly high amount of vigilance for those things. But really, the exhausting thing about dealing with a COVID unit is talking with patients and family members, and certainly with Delta, since we have a lot more unvaccinated people, since we have a lot more misinformation about what constitutes good medical care, and the patient's ideas of that often differing from ours, or what we know to be the truth, that creates a huge amount of tension, and it's a lot of emotional weight that you carry into that unit and out of that unit every day. You spend a lot of time talking to people and trying to get them to understand that what they think they know about the disease is not the way it is.
And that must be really hard for you as staff. You're working so hard trying to save people, but at the same time you've got people who sound as if they might be angry with you.
Yeah, it's been one of the most challenging things to deal with. I think just the work hours alone with COVID for our nursing staff, for the ICU nursing staff and the NPs and the respiratory therapists and the cleaning staff and the physicians have been brutal by themselves. If you add on top of that the fact that you're doing this, taking care of patients who oftentimes, now not all patients are like this. Some patients are very pleasant and just want to get better and are, seem to not have just realized that what was at stake. But certainly a lot of them during the Delta wave have been outright antagonistic. We've had patients who yell at nurses, and I think that takes a psychological toll on the ICU in general. I know way more nurses and physicians and other staff who are seeking out counseling now on the tail end of Delta that never would have considered it before.
And are you seeing some patients who are almost, undergoing the realization that this is a real disease, that they are now, very, very ill and might not recover, and that maybe they have made a big mistake in not getting vaccinated? To watch that realization for somebody is also difficult.
Yeah, there's plenty of those. I think when the people are sitting in the ICU, dying in many cases for 4 or 5 weeks, that's a lot of time to think about your family, your kids, and many of them have young kids, and what you're leaving behind. And so many of them have left behind widows and children that are going to grow up, without a father or without a mother. That also is devastating for the staff to watch, because those people often are regretful, but the disease is indiscriminate. The disease doesn't care that you wish you had gotten the vaccine or not. And it's even harder to watch those people succumb to the illness.
Around the world, many pregnant women are being hospitalised with COVID who haven't been vaccinated. Are you seeing pregnant women as well?
We've taken a number of women who come in to our sister facility pregnant, deliver, sometimes emergently, and then get transferred to us for ECMO. So that has happened, and many of them have died at our facility. And of course, that's a whole nother level of devastation to watch.
Dr. Brett Campbell. Matt, I can't really imagine how this might be affecting the mental health of staff, because it sounds like such a difficult situation to deal with. And patients are entitled to their opinions, of course, and are really ill, so he has to treat them kindly.
That's exactly right. I mean, I think we've seen that it's been taking a very serious toll, and it's making it very challenging for those who have dedicated their lives to helping people to continue to do so in a way that is compassionate and understanding. But obviously that is what they are trained to do, and so they push ahead, but it clearly is taking a toll. And
I guess then if you've got staff who are off with stress, then that makes it even harder for everyone else on the ward.
I think that's right. I mean, fortunately, we are in many places going through periods where COVID is starting to recede a bit, so the numbers are not quite as bad. But I think we can anticipate there will be continued waves, and with shortages of staff, whether it be because there just aren't enough people to be able to care for all the patients, or because clinicians and other providers are taking time off because they are under such stress, means ultimately we can't provide as much care and as high quality a care as we would like for those patients who are in most need.
And there are, of course, even a few medical staff who are choosing not to get vaccinated, despite the evidence that they're seeing before their eyes.
That's exactly right. I mean, here in the U.S., we are seeing that there are some healthcare workers who are deciding not to get vaccinated. And because those are healthcare settings, there are vaccine mandates for those populations, meaning that they can't continue to work. And that, of course, exacerbates the shortage of healthcare workers, putting even more pressure on those healthcare workers who are remaining to care for the sick.
Have those mandates encouraged some people to come forward and get vaccinated?
They absolutely have, but they also have led to some healthcare workers not being able to work, and some leaving the profession because they are choosing not to get vaccinated, and it's a requirement.
Now, Dr. Campbell mentioned there the pregnant women that they're seeing who haven't been vaccinated. And this is interesting because the guidelines for pregnant women, they do vary in different countries, don't they?
They do. Fortunately, it's a fairly fluid situation, and the number of countries that are recommending pregnant women get vaccinated is increasing all the time. So, for example, if you look in Russia, formerly their recommendations were against pregnant women getting vaccinated, and they have now moved to fully recommending those for pregnant women. Same is true here in the United States, where the guidelines did not prevent pregnant women from getting vaccinated, but they were not a priority population being targeted for increasing vaccination rates, whereas now the United States, Canada, Mexico, and are all switched to policies where they recommend pregnant women do get vaccinated.
And it does matter, doesn't it? Because in England, for example, recent figures showed that almost a fifth of the most seriously ill patients in hospital with COVID now are pregnant women.
It absolutely does. It's very understandable that those who are pregnant have concerns about getting an injection at a time when they have a vulnerable life that they are caring for in their bodies. But at the same time, the evidence is not pointing towards increased risk, but there is increased risk with getting infected. We want as many of those women to get vaccinated as possible so that they are able to remain healthy both for themselves and for their children.
Now, there is a new study out which should prove reassuring for women, which looked to see whether there was any difference in the rate of miscarriage between vaccinated and non-vaccinated women in early pregnancy. And this was done by a team at the Centre for Fertility and Health at the Norwegian Institute of Public Health. Now, in Norway, pregnant women aren't vaccinated until the second trimester of pregnancy unless they've got underlying conditions. So one of the researchers there, Maria Magnus, told us how she did the study.
So the women who were vaccinated in our study were most likely vaccinated prior to realizing that they were pregnant, or they might have had a particularly high risk for severe disease from COVID. So what we did in this study was to compare women who had experienced a miscarriage during the first trimester and women who were still pregnant when entering the second trimester. We compared the proportion who had been vaccinated 5 weeks prior to the date of registration of a miscarriage or confirmation of an ongoing pregnancy. And we evaluated this 5-week window because we think it's highly unlikely that any women will seek contact with the healthcare services prior to at least having missed one period. So we are fairly confident that the women were indeed pregnant at the time that they were vaccinated.
Matt, it sounds quite complicated. Is it harder than it sounds to do research on this, to find out the evidence that we need?
Well, it is a little bit challenging to use existing registry-type data like they've used in this study, not because the data doesn't exist. There's lots of data, but the data is often incomplete. As they said in the piece, most of the women who would be vaccinated in this study during their pregnancy would be vaccinated during the second or third trimester. But because some women would be vaccinated during a time period when they didn't know they were pregnant, some women would actually be vaccinated in their first trimester and not know it. So sorting out the timing is challenging.
Well, and here's what they found in that study.
So after accounting for various background factors, we actually found that women who had experienced a miscarriage during the first trimester were less likely to have been vaccinated than women who were still pregnant when entering the second trimester. So we saw no indication that vaccination increased the risk of miscarriage.
So these are reassuring results. Is part of the problem that because pregnant women weren't included in the earliest trials of the vaccines, that's left people feeling more uncertain and not being sure?
I certainly think that is a part of the problem. It's reasonable when you're dealing with a new vaccine to want to test it on generally healthy adults before you move into testing it on pregnant women first. And so, that was a decision that was made. But ultimately, I think that these concerns would arise even if pregnant women had been included in the original trials, because it's a time when pregnant people are understandably concerned about anything that they are consuming or any kind of vaccinations or that they are getting. So, I think this would have occurred no matter what. But certainly, not having pregnant women in those early trials probably contributed to some of the concern.
And so now that there have been some studies, to be clear, the latest thinking is that it's safer to get vaccinated than to catch COVID if you're pregnant.
That's exactly right. There is risk of negative outcomes from a pregnancy associated with getting infected. And so getting vaccinated has not been shown to increase risk. And so right now, all the evidence points to pregnant women should be getting vaccinated.
Well, thank you very much, Matt Fox from Boston University, for joining me today. And thanks to the producer, Erica Wright, and our studio engineer, Donald McDonald. You can find me on Twitter and Instagram at Claudia Hammond. Next week, the women with so much spare breast milk that they give it away.
I actually was producing so much that I had to buy a humongous freezer just to put it all in. And I bought this huge freezer solely for my milk.
And remember, you can subscribe to Health Check from the BBC for nothing, wherever you get your podcasts, and then new episodes will appear as if by magic every week. Bye for now.